Donc, bonjour. Avant de
Hello, everyone. Now, before we go into the heart of the matter,
avec ce qui vient d'être
and as a cue to what we've just been discussing on Lassa fever,
on est tous une pensée
I'd like us to
notre chère
have some thought
Lucille
for
Saint
our dear colleague, Lucie Saint-Louis, who is a physical therapist, because in the course of a training session in Nigeria, and she was extremely committed to physical therapy for young children and toddlers, particularly malnourished infants and children. And it is working wonderfully. And she died in February last of Lassa fever. So I'd like us to, think of her, pay tribute to her, and also understand that what we do in order to control Lassa fever is also a tribute to what she did, her work, and our heart goes out to her and her family.
les nouveaux
Now we are going to start our session on emerging health challenges, evolving needs, and adapting responses to field realities. Now, there are four presentations, and you may have a feeling that these are very different topics. However, the common denominator across these four presentations is that whenever there's a new challenge, there's a new disease, MSF are always very committed to try and do something about it, even when we are told that it's going to be impossible, even when we are told that treatment is going to be expensive, too expensive, or even when we are told that patients are not going to comply with treatment. I think it is very important because this is how we end up with a gold standard that can be applied in a very difficult context, in very difficult settings, because we try and we do our utmost every time, and more particularly thanks to Epicentre. You cannot hope to face and meet these challenges without the support from Epicentre, without research that underpins everything we do in our settings, because we are faced with questions that are very different from what we see in high-income countries. So working with Epicentre is absolutely valuable. It's been ongoing for so many years now. And whenever there are new challenges, we can see that we are always capable of working hand in hand. I'm going to give the floor now to Claudia.
And I will start maybe with a small introduction, because we are starting with a presentation on HIV, and many of you in this room will tell me, really, a new challenge? We have been there 20 years ago when we all did together the databases to follow up patients. We were all together when we said we are able to treat patients, and Epicentre did the data collection, and many of you have been part of this adventure. And a few years later, we decided to say we can not only do this with a good adherence, with a low mortality, we can have quality care for our patients, we can also do this on a large scale. So we had these enormous big cohorts of patients that we followed over the years, and I see so many faces that have been part of this. We have been in this together. And we followed them over a long period. So we looked also at resistance on the second line, third line treatments. We accompanied the introduction of new treatments like dolutegravir in Malawi. We looked, and there was something that changed with this scaling up, and that was also our ambition. That at one moment we said, we do not only want to do the best treatment for these patients, we also had ambitions of public health ambitions, like we want good coverage. The famous 90-90-90 objectives, we were there and we said, we want to even reach higher. We want that everybody who is infected knows his status, that everybody who knows his status gets treatment immediately, and that everybody who is on treatment is immunosuppressed. So it's an adventure that we have been accompanying with the data all along. And I think it is a good example that, yes, it's not only it's not a new challenge, but it is adapting and changing all the time. Because with the fact that we afterwards handed over these big cohorts to ministries, we now started to look at different subgroups, right? We looked at adolescents, we looked at sex worker, we looked at migrant populations with specific needs to tailor the treatment to these patients. And again, this was accompanied by studies. And these adventures, we are going through them, I think, together. And there are new challenges coming and new opportunities. And this is what Quiwa will talk about. Because now we have the injectable antiretrovirals. And and on top of it, a specific population and on pre-exposure prophylaxis. So with no further, how do you say? Adieu? After this rapid go-through, that was rapid, huh? I'm trying to catch the time. Please come, Quiwa. Oregon is our epidemiologist in Malawi, and she's following the HIV project. So welcome, Quiwa.
Thank you. Good morning. We are presenting today preliminary findings from our study on uptake and persistent use of long-acting injectable cabotegravir, or CABLA, offered as a HIV prevention to female sex workers in Malawi. So despite considerable progress, HIV remains a concern in Malawi. With an estimated prevalence of 6% and a striking 53% amongst female sex workers, and ongoing transmission as well, recently a new tool has become available, long-acting injectable PrEP, which marks a major advance in HIV prevention. So 2 PrEP options relevant in our context are firstly oral PrEP, which requires daily medication intake, but has known challenges in terms of adherence and persistent use. And secondly, CABLA, the first ever long-acting injectable PrEP, requiring injections in the buttocks every 2 months. The clinical trials showed high efficacy and good tolerability, but with injection site pain as a common side effect. While CABLA is sought to overcome the challenges associated with oral PrEP, we lack real-world evidence, and including for sex workers. So MSF is supporting a community-based sex worker project in Dedza and Nino district, with mobile outreach clinics providing sexual and reproductive health services to 21 different female sex work hotspots. So oral PrEP has already been available, but uptake has remained low. CABLA was introduced in January 25, with initially limited capacity due to global supply shortages. Offering CABLA as an alternative PrEP option through this community-based model is expected to support PrEP use amongst female sex workers. So our study objectives are to assess uptake, preferences, and persistent use of both PrEP alternatives, to explore respective barriers and facilitators of PrEP use, and to evaluate feasibility and acceptability of PrEP provision through outreach clinics in sex work hotspots. It's an 18-month observational mixed method study, which started in January 25. Quantitatively, we use routine data, analyzed descriptively with a multi-state model framework to assess PrEP use over time. And qualitatively, we include both clinic clients and PrEP stakeholders through individual, couple, and group interviews. And today, our preliminary findings will be based on data up until March 26, as well as some early qualitative findings. So clinic attendees were predominantly female, reflecting the focus of the project. Median age was 26 years, ranging between 14 to 78, including minors, but mostly young adults. Most clients were new to the clinics, and engagement in sex work was varied, from being the primary source of income to intermittent or no engagement at all. High mobility was also common, with cross-border movements between Malawi and Mozambique. And shared vulnerabilities included food insecurity, stigma, violence, and limited legal protection. Shown here is PrEP uptake over the current observation period. So in total, 1,393 clients were offered PrEP. About half accepted PrEP assessment, and then nearly all of which were started on PrEP, resulting in 742 PrEP initiations. Of those, 41% started with oral PrEP, and 59% started with Cabla. And just to note as well that 70% actually preferred Cabla, but 59% could receive it on an initial prescription, mainly due to the supply constraints we faced. So this graph illustrates PrEP prescriptions at follow-up visits after initiation. Among those who returned for PrEP, prescriptions continued, but mainly for Cabla, as we can see in green. Furthermore, 1 in 5 oral PrEP users actually switched to Cabla once capacity is allowed, but only 3% switched from Cabla to oral PrEP. And this was mostly due to pregnancy, as current Malawi guidelines insists. Pain, swelling, lumps pain, swelling, and lumps at injection site were reported, most commonly on the first 4 injections. But the pain was described as substantial. However, there was no medically induced discontinuation. No HIV seroconversions were recorded amongst those who returned for PrEP. So, yep. So here we actually have the same graph, but now we've also added those who did not return for PrEP. We've grouped them into 3 categories. So firstly, in yellow, as you can see, we have off PrEP. This refers to missed or late appointments. In orange, we have lost to follow-up, defined as no return by more than 2 months. In pink, we have stopped PrEP, which refers to those who actually returned to the clinic and reported stopping PrEP. So overall, we had disengagement from PrEP. It was substantial, as you can see. It mainly occurred after the 2nd and 3rd visit, and it was mostly attributed to loss to follow-up. Next, we used a multi-state model framework to estimate PrEP use over the full 12 months. The table shows probabilities of being in PrEP follow-up states on the left, or PrEP exit states on the right, at 3, 6, and 12 months. We used the same categories as I've previously introduced. So at baseline, we observed that 41% started with oral PrEP and 59% started with Cabla. Oral PrEP then drops rapidly by 10-fold to 4% at month 3 and 3% at month 12. Cabla use, on the other hand, reduces less and decreases more steadily, stabilizing at 30% by month 6. Off PrEP range between 17 to 5%. And lastly, amongst the PrEP exit states, loss to follow-up is the most dominant one. Nearly 1/3 of PrEP users are estimated to be lost to follow-up by month 3, and about half by month 12. The probability of actually returning to the clinic and reporting PrEP discontinuation remained small. So qualitative interviews also highlighted several factors influencing both PrEP uptake and persistent use. Most participants were aware of PrEP, and mobile clinics were perceived as accessible and non-judgmental. Cabla was preferred, as it allowed for discrete use, eliminating the need to remember a daily pill. But barriers included the fear or the experience of side effects, nausea, malaria-like symptoms for oral PrEP, and injection site pain, swelling, lumps with Cabla. Additionally, there was stigma and violence associated with PrEP use, but mainly with oral PrEP. The risk of being seen regularly at the clinic by community members, peer pressure and misconceptions, and for Cabla specifically, currently limited access sites in Malawi for clients who are mobile. So here we share some voices from our participants. Firstly, regarding Cabla preference and its discrete use, one user explained, like the friend I told you about, who was asking for PrEP from me. She was shy to go and get it. She thought that maybe when she carries the bottles, someone will see her. So injectable is better because no one will know that you are on PrEP. Another Kabla user illustrated the livelihood impact that Kabla injection site pain located on the buttocks can have for a female sex worker. For you to sleep with a man, they need to touch your buttocks, and your waist should get involved, but you are in pain. You can't be able to do it. It happens that the days you are in pain, you are just staying at home and can't work. Sorry, I've lost my notes. So in summary, we observed moderate PrEP uptake and with a strong preference for Kabla. Ongoing PrEP use was predominantly with Kabla, with the probability of staying active at 12 months around 10-fold higher than that of oral PrEP. There was also substantial PrEP disengagement, starting early around the second and third visits, affecting around half the cohort by month 12. PrEP uptake and persistence were shaped by contextual, social, and individual barriers, while the discretion offered by Kabla facilitated its use. And so, as we have seen, Kabla has shown the potential to boost PrEP uptake and persistent use amongst female sex workers, but we also see gaps. Key strategies to address these include further sensitization in sex work hotspots, strengthened counselling at PrEP initiation and follow-up visits, and to ensure a linkage to the now expanding Ministry of Health Kabla delivery sites. And just as we look ahead, the next generation of long-acting injectable PrEP, lenacapavir, requiring only 2 injections per year, will soon become available. Enhanced monitoring should continue to further guide delivery models, support strategy, as well as supply. So thank you to everybody who is involved, and thank you for listening.
So thanks a lot, Griwa. We will have the questions and the discussion after all the sessions. But just to thank you for this brilliant presentation, and it's a real game changer, and I think we'll have a lot of discussions afterwards.
Maintenant, je vais inviter le docteur de San José, Sylvia, qui est médecin avec un PhD en épidémiologie, qui a consacré une grande partie de sa carrière à travailler sur les liens entre le virus papilloma et les cancers. Elle a travaillé au sein d'instituts prestigieux, que je ne vais pas pouvoir citer tout cela, mais en tout cas, parmi lesquels il y a le Centre international de recherche contre le cancer, l'Institut de santé globale de Barcelone, le National Cancer Institute aux États-Unis. Elle a présidé l'International Papillomavirus Society. Et je peux dire que c'est quand même une des plus grandes contributrices mondiales à la compréhension de l'HPV et du cancer. Et je le pense sincèrement. La parole est à toi.
Merci beaucoup. C'est un plaisir, un honneur d'être ici. Je vais parler en anglais parce que je suis plus entraînée avec la...
Oh, it's a...
I am going to talk about the project, which is a novel screening and triage approach to detect cervical precancer using 2 tools. One is the HPV that we call extended genotyping, and I will tell you more about it, and an AI approach to evaluate the cervical images. The interest of me being here is because Epicentre, MSF, and MSF Foundation have been contributing to this project in many aspects, not only in the discussions, as well financially and with their human power in the field in Malawi, with a contribution of over 6,000 people in the overall project. So let me tell you about the cervix. We are talking about a very small part of the uterus that contributes to 90% of the cervical cancer cases, and it's at the end of the uterine cervix of the uterus, sorry, and it's constituted with 2 different types of cells, squamous cell and glandular cells. And all these are shaking according to the physiological changes of the vagina and reproduction, and makes these cells very, very agile, very transforming. And this makes them extremely susceptible to HPV infection. It's a unique place in the human body that has such a high fidelity for HPV. So the cervix is cervical cancer, invasive aspects of this tumor is really a major public health problem. We have estimations about over 600,000 women would have this disease every year. As you can see in the maps, the dark blue it represents incidence, the dark red represents mortality. Half of the women that will have this disease will die due to this disease. And unfortunately, 80% of these deaths will occur in sub-Saharan Africa in low-resource settings. So we have a problem that is a very important inequity based on the geography where we live. And this is largely due to the activity and the prevention that we can do against this disease. So we know today that HPV is the cause of cervical cancer. We have thousands of studies that have demonstrated that. What is very interesting is that we have many, over 200 HPVs, but not all are responsible of cancer. And now the International Agency for Research on Cancer classifies 13 HPV types that are group 1 or 1B that can cause cancer. And these are really our target for HPV prevention. And here I have grouped them in different colors, and this is a very important concept for you to follow. The types are ranked based on the attribution that they contribute to invasive cervical cancer. For example, the number 1 in red is 16, contributes more than 60% of the cervical cancer. So if we remove this HPV 16, the incidence of this disease will be reduced by 60%. So then we go 1845, the second most common, which are very important for adenocarcinoma. Then we have the green group, which is an intermediate risk, and then which account for about 10% of all the cancers. And then we have the blue group. And I'm telling you because this is very important for you to understand what we are doing. The blue group are types that have been checked and that they are carcinogenic. But the chances that a woman infected by this type evolves into invasive cervical cancer is very, very low. So they contribute, you can see, less than 5% of the overall invasive cervical cancer. We have learned very, very well the natural history of the disease. We know that we acquire HPV infection in the red shape that you can see here soon after sexual initiation, and then the majority of us have a good immune system, good enough to really clear the infection, but they remain about 10–15%, depends on the setting, that will have this infection as a persistent one. Now we know that we can prevent the evolution of the infection by HPV vaccination, that it's all over the world now. About close to 40% of the girls before age 15 have received this vaccine, and this will prevent this curve. If we prevent this curve, then there will be no disease. But for the women that have not had the chances to have this vaccine, we have to go through a screening. And so while in France you will have 14 visits to get a screen all over your life, when we go in low-resource settings, we have the possibility to screen once or twice in a lifetime. So here is the drama, here is the inequity in health. So WHO is very concerned about that and launched a call for elimination of cervical cancer. This means to reduce really the new cases to a very low level so that it doesn't remain as a public health problem. The main pillars that they call for is 90% vaccination of girls before age 15, 70% of the women between 35, 45 should have a screening test based on HPV, so it's very important that. And any woman that is detected to have a lesion or a cancer should be treated, so reaching 90%. So if we obtain this, and all the countries in WHO sign for this, by the year 2030, we would really get, at the end of the century, the elimination globally. Okay? So I go to the PAVE project. PAVE project is trying to really tackle the issues that we have in the absence of screening in low-resource settings. Less than 10% of the women in Africa have ever been screened. So we developed this approach, trying to make it more accessible. This project includes, first step, self-sampling screening. This means that the woman doesn't need to go through a gynecological exam, and with a brush gets her sample of the cervical cells. This approach allows us to test for HPV. And then we will test for HPV using these color blocks that I show you, which will allow us to really stratify the risk of having a precancerous lesion. If the woman is negative, the woman goes back home reassured. Negative predictive value is above 5 years. Those that they are positive, so we have the woman is HPV positive, then we call them and say, can you come to have a gynecological exam with a speculum? We take with a mobile colposcope, we take a picture, and this picture is read through an AI algorithm. Together, HPV and the image, we bring them together and we generate an algorithm that classifies women, let's say, put it very simply, in this traffic light approach. Red is going to be for the operational group to understand that a woman with a red will require an immediate treatment. Women with a yellow average risk will have to be followed up, and based on our capacity to treat, they will be second priority. The women in green, they can go home. So we try to avoid over-treatment, okay? And we, in the whole project, we provide thermal ablation, which is a very initial approach to treat, and we can treat about 60% of the cases that require treatment. The others will have to be referred. So the PAVE project included 50,000 women, 1,400 were living with HIV, 35,000 were sent back home, 13%, which is about 27%, were HPV positive, and we managed to include what we call the efficacy study, that were the 7,000 women that were HPV positive, and we had full data. Full data means we had a good image that we could evaluate, and we had an histology assessment. Every woman had to have an histology because this is a validation project, and we require confirmation that our strategy was working. So as you can see here, the sites that included in the project were Cambodia, Brazil, El Salvador, Honduras, Dominican Republic, Nigeria, Tanzania, Malawi, and Eswatini. The AI during the project was run in Colorado in the US. We were sending these images online, uploading them. Now we can do that inside, and Malawi has been running a project to make sure that we can run this evaluation through the AI with a small mobile colposcope. So here is the results of the overall project, okay? So you can see here in this table, I show the percentage of women in which we detected a precancerous lesion. Precancerous, I mean CIN3, which is the very best precursor lesion prior to evolve to invasive cervical cancer. And the overall background for women overall that were positive was 7%. And you can see in the first two pillars, in blue, HPV 16 positive, the initial risk was 15 if the woman was HIV negative, and it reached to 25% if she was living with HIV. And you can see that in all, the green bars are always higher because it represents women living with HIV. They have always more infection than HIV negative women. And what is important is that this shows the first step. In the first step, we are already able to go from 7% to identify women that have a 25% risk, for example. Then, I think I didn't have the most updated version, but okay, sorry about that, because we had included here another slide in which we show what happens when we take the image. The image of the cervix can be classified in 3 groups: normal, indeterminate, or severe. And it's the severe that we consider it's a marker of disease. When we add the severity of the image together with the HPV information, we can really grade the risk. As you can see, we were talking before about 20%, now we are over 35% in the red bar. What is important is that if a woman has an HPV 16, it doesn't even matter even what happens with the image, because this woman has such a high risk that we need to manage her. But the group that I was showing before, the blue and the green, they have, the image evaluation has an added value. For example, a woman with an HPV 31, if she has a severe image, or an HPV 39, which is a very low risk, has an image that's categorized as severe, the risk immediately goes up. So this allows us to really bring into the field a screen and triage approach that is of very high quality. And I always say, I would be happy to be screened with this approach, okay? So it gives us this green group that as well can be reassured, can go back home, and we concentrate our operational activity into those women that need to be treated. So in summary, based on our PAVE work, we had categorized as immediate need for treatment 57% of the women that were HPV positive. 22% remained like, do as much as you can according to your ability. And then 21% can be sent home with a good safety. Doing this approach, and by managing the red and the yellow, we target 98% of the cancers, and precancers, sorry, precancers and cancer. 2% are missed, which are in this green. There is no another screening test that what we are doing here that in one visit can reach this approach, okay? So to summarize, very briefly, the PAVE strategy highlights that HPV and ABE can provide a good risk stratification of precancerous lesions, and PAVE aims to support clinical management. When we have it implemented, it will be a very good aid for the operations on how to really do the best for those women that they are more in need. And I want to thank my colleagues. This is a big consortium, a very good thanks to MSF Foundation as well for supporting part of our job. Thank you very much.
Merci beaucoup, Sylvia. Donc, juste pour donner un petit mot du Malawi.
Many thanks, Sylvia. About Malawi today, we shifted from research to the routine application of this implementation of this screening and triage algorithm. I imagine we'll get lots of answers after the 4 presentations, so I will not dwell on that now. And let us move now to the presentation on sickle cell disease. Farah is an epidemiologist. She works in Epicentre in Dakar. She is doing a PhD science dissertation at Geneva University. And Delphine Sauvageau, she's an epidemiologist. We're so happy to see her again at Epicentre. She was with us a few years ago. She's greatly experienced in epidemiology with various institutions and NGOs. Both of them will now share their work on sickle cell disease.
Good morning, everyone. We are very pleased to share with you today our result research on sickle cell disease and hydroxyurea use in rural remote area in Niger. Seeing the site of the study and where we are today, I will kindly ask you to listen me in French. Good. Alors, la drépanocytose est une maladie.
Sickle cell disease is a widely spread genetic disease in Africa. In Niger, 1 out of 10 people has SCD. Patients show repeated painful fits and other complications, the shape of the red blood cells that end up obstructing the blood vessels. HU, hydroxyurea, reduces greatly those complications and improves the prognosis for the patient, but its use in Africa is often restricted to specialized referral centers for sickle cell disease, SCD. In Niger, the use of HU is limited because of the high cost, the cytotoxicity, and the lack of availability or other reasons. In this context, MSF supports the management of SCD in Niger since 2019. The preventive care package of MSF includes prophylactic treatment, clinical laboratory and nutritional follow-up, therapeutic patient education. In February 2026, 3,300 children were already included in the cohort of the children followed in Niger. In 22 and 24, MSF introduced as a pilot program hydroxyurea, HU, for the management of those cases. To date, 70 children are under this treatment. Following the introduction of this pilot treatment, we asked ourselves, what about the feasibility and acceptance of this treatment, and what is the perceived quality of life among children treated with hydroxyurea? Is it improved? And then we wanted to evaluate the frequency of complications in all the children in the cohorts. We did 3 additional studies for that. First, a quantitative prospective study aiming at evaluating the evolution in the quality of life of the children treated with HU. Second study to evaluate feasibility and acceptability of HU treatment in this context. And then a quantitative study that will describe the incidence of complications for the whole cohort. The first 2 study, that's what my presentation is about, because the other one is still work in progress. So first study, and then my colleague will tell you about the qualitative study about feasibility and acceptability. Now let's focus on the quality of life of the children. We used a self-assessment questionnaire to evaluate the quality of life with 9 dimensions, 43 items adapted for children. It was administered directly to children under 15 and their parents, representing the children aged 2 to 4 years old. Data collection was done at HU initiation at 6 months and 12 months. The respondents had to answer graduated answers on a scale of 0 to 4. And then we did a logic score attribution from 0 to 100. The higher the score, the better the quality of life. The average score, we took the average of the 43 items. Now, the dimensions we assessed for the quality of life, 9 of them. First is pain. We evaluate the frequency and intensity of pain, and it goes all the way to the communication. That is the ability of the patients to talk about their disease with the caregivers and also with their relatives. The results, we had 30 children, 67% were girls. All the children had sickle cell disease, and they had had at least one complication in the year prior to the initiation of HU. So quality of life, the score of quality of life, initiation at 6 months, we did note a significant improvement in the quality of life of the children, and it was even more marked at 12 months. You go from a score of 67 to 90 for a maximum value of 100, I remind you. We looked at the various dimensions. As you can see, for pain criteria, the worries of the children, fear, all that was improved, emotions, concerns. But the dimension on the communication of treatment and the daily burden of the treatment, it was improved also, that block, but not as significantly. But of course, when you introduce a new treatment in the follow-up, it makes it a bit more tricky.
Merci Farah. Donc moi, je vais vous parler de la faisabilité de l'acceptabilité.
Thank you, Farah. I'll be talking about a feasibility and acceptability study which was carried out in Madarunfa, Niger this year, based on semi-directed individual interviews with children aged 9 to 15, their parents for younger children, healthcare professionals and health authorities. The data collection was made over 2 months, and then we performed a thematic analysis. Out of 49 interviews, we could collect data on 22 children who were had 3 years of follow-up in Madarufa, and there were 21 healthcare professionals who also had a 4-year experience with sickle cell disease treatment. All participants have shown or reported that HU is extremely efficient. Effectiveness, because there is limited healthcare utilization, few hospitalization, no blood transfusion as opposed to what they had before treatment. Pain management had improved because it was possible to have self-medication and more socialization of these children who could play with their peers and could go to school, which was not possible before. Mothers were also proud and said that their children were full of energy, that they were, fighting in the streets with other children, and that they no longer looked tired. And this changed also the family relations. The father, who was absent and was not involved in the management of their children, would go to the consultations because there was no need for hospitalization. Mothers could engage in other activities, and it decreased the anxiety level in the family because there was no longer need to go to the hospital. The cognitive performance of children also greatly improved, and this, gives an opportunity for some future in these children now. What were the determinants of adherence and acceptability? With a lot of pain, going often to the hospital, these were determined to accept a new treatment. Many families felt that they were relieved once they had understood the impact of the genetics in this disease. And in terms of barriers, we have noticed, like in many other studies in rural environment, that access to traditional medicine was the first-line treatment, and it would delay the actual medical treatment. Community influence is also great, and the solution that was suggested to the families for those children with sickle cell disease was to start a divorce. And so here, there was a kind of new deal. The fear of infertility, that before starting a treatment, there pre-initiation, and the physician will say that there's a risk of transient infertility. And this is where we had many loss to follow up, because fertility in these areas is of great importance. So the teams have managed to change the trend is by informing fathers, because fathers are the decision makers. So at the time of initiation, informing the fathers has helped to have more adherence. No, the mother was usually in charge of taking care of the children. At the beginning of the treatment, we have 500 milligram capsules which were given. And because of these posology were not given every day, sometimes it was 2 to 3 times a week. Sometimes they forgot to give the treatment. And also for very young children, it was very difficult to digest, and they were under dose. So with the new formulation, 100 milligrams, there was a great improvement. And also there's the cost of transportation. Even though treatment is free of charge, families had to pay for transportation to the health center. And that's a problem for families to go there every 3 months because of the financial impact. There is no reminder of the appointment or of the need to take the drugs. And also great problems in accessing the areas because of the rainy seasons in some regions. Now, regarding the hospital-based implementation, 2 nurses and 1 physician were rather well trained, and they were well supported, access to expert, but the waiting time during the peak periods was rather long because the physician was also involved in emergencies and because many sickle cell patients are sensitive to any climate-related event, and they will have more complications at that time. So these patients were not on HU treatment. And because of the new platform, which is now automated, it's easier to follow up the patient in a more efficient fashion. But there could be some delays because there were too many emergencies. We've had some supply stock out problem, but for the general program, there is people are highly motivated to be trained, not only the referent person of the program. So it means that the teams are really thrilled about it. So conclusion, results were quite encouraging for these children with severe symptoms in rural areas. This translated into an improved quality of life, a better pain management, opportunities for socialization, a good treatment acceptance. This could be even further improved through community awareness raising and maybe some, with peers explaining the interest of HU treatment, like it was the case for ARVs with HIV patients, and maybe consider some reimbursement or transportation cost, and hospital-based implementation with areas of improvement for adherence monitoring, better planning and expansion. Conclusions. They all want that there should be a wider coverage of treatment for these children. And thanks to the bargaining for affordable prices, we've had some treatment which would cover up to 500 children in Niger. And that's a great opportunity because it will help us to start new management strategies like reaching out to the beneficiaries through decentralizations of treatment like it was done for ARVs, and consider reviewing the eligibility of children or delocate either the medication dispensing or even the blood sample collection. It is important to support the scaling up with more screening services and developing a clinical algorithm for patient referral and also advocacy so as to have better access to medication at the national level at an affordable price. Thank you to all the teams who were involved in these programs in Niger. Thank you.
Merci beaucoup. Donc ça, c'est vraiment
Thank you very much. It was the very first time we were treating patients with HU at MSF. It was a pioneer study, and I'm pleased to say that in Uganda, since the beginning of the year, more than 200 children are treated with hydroxyurea.
les cohortes.
And so the cohorts will be bigger.
Très bien. Et on va passer directement à la dernière.
Now we'll move on to the last presentation.
Pour cette présentation,
And for this one, we'll look at
IPC.
ABR, IPC, and I'm inviting Jasper, who is going to talk about,
Il est IPC,
he's the IPC advisor at MSF.
2021.
He's been with us since 2021, in charge of the mobile implementation before that.
Okay, go ahead. Yeah. Sorry, go ahead.
Hopefully it will be as interesting as the others. So this is under development with Epicentre. So I'll briefly discuss about our project, which is Healthcare-Associated Infection Surveillance and Alert Tools, or HAI SAT. We also call it like nosocomial infections or hospital-acquired infections. So healthcare-associated infections are infections acquired during healthcare delivery, so that were not present at the time of admission. So they remain actually major patient safety concerns across the whole world. According to WHO, around 7% in high-income countries, while 15% in low-resource settings that acquired at least one healthcare-associated infection during the healthcare delivery. So there are different kinds of HAI, what we call, that are increasingly linked to multi-drug-resistant organisms and may occur as isolated cases, actually, and clusters or possible outbreaks. Despite this burden, many resource or low-resource countries, like in what we work in, still lack structured HAI surveillance systems capable of identifying trends, clusters, and outbreaks in a timely manner. As a result, they may only become apparent after multiple patients are all affected. So why is it important to have that or monitor them? It's because it helps evaluate whether healthcare systems or what we work in and our IPC practices are effectively preventing patient harm. Importantly, HAI surveillance does not replace our clinical diagnosis as clinicians. I'm not a clinician, I'm a nurse, by the way. So clinical diagnosis focuses on individual patient, while HAI surveillance, we want to focus on transmission risks and outbreaks at population level. So therefore, relies on standardized definitions to support more consistent interpretations across settings. So in most MSF-supported facilities, surveillance remains difficult for several reasons. Clinical information, laboratory data or reports, and patient monitoring are often fragmented across paper charts, registers, and informal communication systems such as sometimes we have used WhatsApp. So existing data are difficult to analyze operationally, and possible outbreaks of multi-drug-resistant organism transmissions may be recognized very, very late. So this creates the need for more structured approaches for data collection, interpretation, and reporting that remain feasible within the humanitarian field settings or realities. So what is the project for? So we use multiple clinical, so in MSF, basically, we use different kinds of data collection systems. So that includes the HIS2, Praxis, or sometimes we use an Excel base or registers, and then you heard about HUNET as well, that has an integrated SAT scan. However, this does not answer all the field's needs. So HAI SAT is designed to interoperable with 3 existing systems and complements them, adding standardized HAI definitions by WHO together with clinical and IPC context needed information to better assess whether these signals represents healthcare-associated infections or HAI transmissions. So the existing tool that we're using is Kobo Collect. It's comparable with ODK. clinical data collection system and microbiology results from WhoNet that will be merged in one line automated pipeline and merged into a single line list. This supports standardized HAI indicators, trend monitoring, cluster identification, and possible outbreak alerts while remaining adaptable at the operational context. So this is an example of screenshot or callback data collection system. It's mostly like an algorithm questionnaire that follows specific yes or no binary questions, answers. And then this is the visualization dashboard that is simulated or dummy data, so don't mind with the information like the 100% HAI, no. So we're starting going to be more numbers, and then we will go into rates or incidence rates in the future. So why, so this is my last slide, so why is it needs to be addressed right now at the fields? Several operational gaps that still exist in HAI surveillance across MSF supported settings. So first, the project itself aims to improve the surveillance itself by transforming fragmented clinical, laboratory, and IPC data into more actionable surveillance information, together with more standardized interpretation of HAI events across projects. Going back. Second, the tool aims to support earlier operational response to earlier recognition of HAI trends, clusters, and outbreaks, and while supporting faster IPC and operational decision-making in high workload settings rather than it's too late that usually happens in our projects. Finally, beyond the routine surveillance, the online platform may also facilitate remote technical support. So basically people maybe in the headquarters operationally follow up while generating data for many or may support IPC improvements, activities, and future operational research. So the system is also being developed with data protection and controlled access consideration integrated within the workflow. So to follow the recommendation with our data protection team. So the next steps are education and training tool, pilot implementation later this year, evaluation, and possible scale-up in other MSF projects. So in the future, this approach may tailor to surveillance in settings without microbiology laboratory capacity through use of clinical symptoms-based monitoring. It could also be adaptable beyond MSF-supported projects because we want to secure and support ministries of health as well, depending on the context and feasibility. And that's it. Thank you very much.
Thank you very much, Jasper. That was fast. And I think it's a super interesting and important project that will help us to identify hospital-acquired infections and outbreaks, and it's a big topic for all of us. So maybe we'll pass directly at the questions. If there are any, maybe there are any questions in the room. I know that this was like a big bandwidth of different topics, so don't forget we had Kabla, SPREP, we had PAVE, we had Sickle Cell, and this. So please ask questions to all of the participants. There's a question here in front, and another one there, Estelle. And
hi. Sorry, I have 2 questions for the study done with HIV prophylaxis prevention in Malawi. There is a similar study done by OCB in Mozambique, and I was wondering whether, I mean, the 2 studies were, what were the difference in the 2 studies? I think the other one was targeting key population, so including sex workers, but also men who have sex with men, and maybe a great variety of group. But I'm not sure if the results were similar. I don't know if you know of that. And my second question is, why such a high number of drop-off on Kabla, not oral PrEP, but cabotegravir? Is there something specific about this population that make them, you know, stop treatment even on these like every 2 months injection? Because I think I remember that they were moving up a road, and that may be the reason. But yeah, thanks.
Thank you for your questions. The first question about the study in Mozambique, I'm not 100% in the loop, but as far as I know, they're very similar. But I think, unless somebody can correct me, they're evaluating not just female sex workers, but some other groups, including men who have sex with men, different key populations, basically. But that's as far as I know on that project. Your second question about the loss to follow-up and the drop-off with CABLA, we had significant drop-off from oral prep. In fact, as you could see from our model, it dropped drastically to, I think, 3% by month 12, and that aligns obviously with our observed data. For CABLA, obviously, we still had drop-off. As you could see in general, by month 12, we had half our cohort lost to follow-up. The reasons for this, obviously the qualitative data is still being analysed, but some of the reasons that we've come across have been due to the high mobility. And also maybe just to note that in Malawi, MSF are the sole providers of CABLA right now in the 2 districts that we're working in. So there's no other access points for CABLA besides the Ministry of Health, who's giving it out in a different 2 districts, so Blantyre and Lilongwe. So once you're mobile, it's quite hard to follow up with CABLA. So that's one reason. And other reasons, as we showed, side effects may have contributed. And yeah, qualitative data is still under analysis, but we shall update you.
Thank you. I have one question here from the internet. This is a question from Ron Waldman. I'm a professor at George Washington University, USA. Questions for sickle cell anemia project. Congratulations to Epicentre in general and to our sickle cell researchers. Were all the children fully vaccinated, included pneumococcal vaccination? There are a lot of loss to follow up. Was there any community outreach? Were there many referrals to hospitals for surgery, all medical complications? He's involved in a similar project in a small island in Lake Victoria, Tanzania, and would like to take contact and to exchange.
So regarding vaccination, as I explained, the preventive package offered by MSF includes vaccination for pneumococcus and other vaccines. And yes, we did take this into account. I know that in Tanzania, a lot of things are being done with HU treatment, and they're much ahead of us. And I would be very pleased to learn from your experience in Tanzania so that we can improve further our program. Thank you very much. I hope I have answered your question.
Frédéric Sor, je suis pédiatre.
My name is Frederick. I'm a pediatrician. I also have a question to Farah and Delphine regarding sickle cell disease. Congratulations first on having started this HU treatment. I know they had been expected this for a long time. You said that HU was expensive, but it's a drug that's been there for ages. It's a generic drug. It's very cheap. What is the cost that you take into account? The cost of transportation or taxes?
Donc, en fait, la forme...
Claire is answering. The 500 milligram is cheaper, but it's not suitable for children. And now there is a 100 milligram formula which has been developed, which is far more expensive. So that's a big issue. But new other generic manufacturers have developed cheaper forms. There are 2 other locations where there is a local production, which not 100% compliant with the current quality standards, generic and pediatric formulas in Nigeria and Dakar. And frankly, having a higher cost for a pediatric formula for an old molecule is part of the huge scandals with the pharma industry that we can highlight. And it's a very interesting topic for access. Estelle, two questions. Adding to what Marion said earlier, the fear with CAB-LA is the resistance to drug. And I know that for this study, we have not been able to assess this, but from what I've understood from those patients who, I'd like to know, for those patients who stopped the treatment, have they other HIV prevention tools that they have designed amongst those that we have follow-up after they've stopped CABLA? And then a question to Sylvia. I'm very pleased to see this project, being more tangible today, and pleased to meet you as well. Have you performed any analysis? Because the WHO recommendations, the new recommendations, have just been updated and published, suggesting extended genotyping for screening. Have you checked the PAVE algorithm performance versus the extended genotyping process?
Better. We contribute with the PAVE data for the guidelines, the new guidelines. So all the data, the 50,000 women, were the only source from low resource settings included in the guidelines. So that is where they use this information with extended genotyping to derive their conclusions, which are a bit complex, I would say. These guidelines, what they really aim is to induce all the work that it's done on screening to improve treatment. So it's go treat. So treat everybody, even if without triage, and that is their very best recommendation. Then, if you have capacity to triage, it's up to your system. No, if you can do a more refined work, do it. And I think what we are saying is that HPV extended genotyping is not anymore a triage. It's a screening, it's a primary screening, because it's at the moment I have a result, I already know that you are in one of the 4 groups, or the 5th group if you are negative. So it's very immediate risk stratifying. I don't know if I answered your question.
So regarding drug resistance, firstly, as we discussed, we didn't have any seroconversions recorded amongst those who actually returned. In terms of what we do, if there is seroconversions, we are ready to send samples to the national lab in a long way for drug resistance testing, but it just hasn't occurred yet. But yeah, it's ready. Obviously, the big concern is amongst the quite large population that is lost follow-up. We can't necessarily kind of trace them, somewhat because of the high mobility and the lack of phones, etc. It's hard to trace them anyway, but also obviously PrEP is a choice at the end of the day, so we can't do the same physical tracing as we do with ART either. So yeah, it is a concern, but there's limitations to how much we can intervene.
Je vais juste lire une dernière.
I'm going to read one last question.
Dr. Sidibé,
Dr. Sidibé, congratulations. I'm writing from Mali, from Krononkou CP project. We're about to integrate this management in our strategy in the addition of the physician and the nurses. Don't you have healthcare promoters where other stakeholders can be involved in your strategy because they can play a role in for adherence, and that's for a sickle cell disease. Is it for a sickle cell disease? Yeah, presentation, yes. And, do you have any healthcare promoters? Well, yes, there is a whole community engagement and health promotion, which was developed for the introduction of HU treatment. visiting people at home. I've talked about treatment, education. Yes. In Niger, there is an association of sickle cell disease patient, people living with sickle cell. They're very active, and they were also involved in this general engagement. So the community engagement was there also in this project. One last question, Suna. Suna from the OCP Medical Department. My first question goes to Sylvia. What is this self-test which can help identify all the HPV strains? Can we use it in our healthcare centers? I've understood it's not based on gene experts, so that's my first question. Second question goes to the sickle cell disease people. It's not a self-test, it's self-sampling. It's the woman who takes the sample from the vagina, and then it's given to the lab. And the lab can be just as small as this. The machine to test the HPV is very small and not cumbersome, and you can check 90 samples in 1 hour. So what was done in Malawi and what I've experienced in Brazil is that women were coming at 8 a.m. We were telling them how to take the sample. There was a room with the lab. The women would wait for the result for an hour and a half. Well, let's say 2 hours approximately. And then immediately we knew who were the positive and the negative case. The negative case could leave the center with a small paper. The positive case were in the waiting room. The gynecologist would call them, and we would start immediately the examination. We've treated 808 women over 1 week with 200 thermal ablation and 21 LEP. So we did that for 1 week. It was far and remote in the Amazon forest in Brazil, and it worked pretty well in 4 different locations. And there were no loss to follow-up. The women would stay, so they could stay in the room for 1, 2, 3 hours. It's not that long. So we could complete the screening triage and start the treatment. And this question on sickle cell disease, wonderful what you've done. What about this infertility, transient infertility with the treatment? But we're treating children and it's a lifelong treatment. Is infertility transient? What is the actual problem? Because that's a barrier.
The protocol is that when they want to have a child, either as a man or woman, they interrupt treatment, and then you plan for pregnancy, and then you can resume HU, and there can be some blood support.
From Adri. So he's asking, bacteremia is less known, and we have little data. So as a referent, what are the strategies to reinforce knowledge and possibilities to diagnose and treat bacteremia, who are very frequent in Africa?
Yeah, this is very doctor to answer. It's outside my. But I mean, we have already a strategy within MSF about the AMR. Our antimicrobial resistance strategy in terms of access to microbiology. And I think one of the things that the projects on our MSF, if we are really considerate on knowing what are the bacteria or microorganisms causing bacteremias in our project, then basically we need to reflect if we need to really have to invest a little bit on access to microbiology so that you could treat your patients better in terms of rational use of antibiotics. So I think that is the best answer for that question. It will be relying on the missions or projects in terms of understanding the burden of bacteremia or sepsis in your context. But of course, for my side as an infection prevention, I'd rather go first to preventing infections, so basically related to bloodstream infections. If we invest a little bit more in resources to prevent those, specifically as simple as cleaning and disinfecting your sites and before inserting your catheters will be the best beneficial preventing bacteremias, basically. Yeah.
Thank you. Et avec ça, on va clôturer cette...
And on these words, we'll leave it there.
This was super interesting, and these are very big challenges for the future, and I think it was good to start discussing for them, many of them in different phases of the evolvement. So thanks a lot to all the participants.